Hello and welcome everyone to the Advancing Care Through Individualized Medicine virtual speaker series focused on AI and machine learning. My name is John Kalantari. I'm an assistant professor in the Department of Surgery and Quantitative Health Sciences and faculty member in the microbiome program at Mayo Clinic. And joining me today as co-moderator is Dr. Khezeli. Dr. Khezeli is a machine learning scientist in the Biomedical Artificial General Intelligence Lab and the Center for Individualized Medicine at Mayo Clinic. Now, before we get started, a few housekeeping items. Please use the Q&A in Zoom to submit your questions. We do have time planned for a Q&A at the end of the session. And for those interested in earning continuing education credit, an email will be sent within 48 hours that includes instructions on how to claim credit. And so today we're delighted to welcome Dr. Uri Shalit as our featured speaker. Dr. Shalit is a senior lecturer at the Technion, Israel Institute of Technology, where he's faculty of industrial engineering and management in the areas of statistics and information systems. His current research is focused on three themes: applying machine learning to the field of healthcare, the intersection of machine learning and causal inference, and bringing ideas from causal inference into the field of machine learning. Previously, Dr. Shalit was a postdoctoral researcher in Professor David Sontag's clinical machine learning lab at NYU and then MIT. He completed his PhD studies at the Center for Neural Computation at the Hebrew University of Jerusalem and was a recipient of Google's European Fellowship in Machine Learning from 2011 to 2014. I should mention that Dr. Shalit and his lab are among the few research groups in the world working at the intersection of causal inference, machine learning, and healthcare. And so we're excited to have him join us at Mayo Clinic today to learn more about his groundbreaking work. So without further ado, welcome, Uri. Thank you for joining us today.
Hi, good morning, everyone. Thank you so much for inviting me and for the very kind presentation introduction. And I'm very happy to be here and to share what we're doing and hear from you. So I'll start. I'll share my screen. Okay, is this showing okay? Can you see it? So I'll start. Using patient data to personalize treatment. So when I started in machine learning, not in the field of healthcare, but when I wanted to go into healthcare, it seemed to me obvious that that's what machine learning in healthcare is about, right? It should use patient data to personalize treatment. And it is one of the ultimate promises of big data in healthcare, and is especially important when there are no clear clinical guidelines about how to treat patients. And as you all know, we have vastly more data about patients than we had in the past. And machine learning shines when data is plentiful. So it seems like a match made in heaven. However, a good portion of healthcare data is observational. It's collected in the hospital, in the clinic, as a byproduct of ordinary care. And if we want to answer the question of how to best treat a patient, we need to keep in mind that that's a causal question. We want to know the causal impact of a treatment on a patient. And answering causal questions from observational data is challenging. And we need to use the tools and language of causal inference in order to do it properly. And that's what I'm going to talk about today. And specifically, the task I have in mind is using electronic health records to create individualized treatment recommendations. And our ultimate goal in my group is to enter such a recommendation system into a clinical trial. So that's kind of what we're aiming for. And the current goal and what you'll see in this talk is before we can enter a system into a trial, I want to build confidence that what we're doing makes sense. And really, causal inference is hard. It's harder than the standard kind of supervised type of machine learning in ways that we'll see soon. So the outline of my talk, I have background, then I'll talk about designing studies for causal identification. I hope I'll explain what that is, and then show the results we have so far. And so we'll start with the background. So here's the setup. Here's the situation I have in mind. Oh, and before I go on, please feel free to raise questions, and I think John and Kia will rally them to me. I don't mind getting questions during the talk, it's fine. So here's the problem formulation. We have a patient, she comes in on May 15, we have her medical record, many measurements, and the physician, the clinician debates between two medications to treat her blood sugar levels. So we call it just medication A or B, or treatment T0 or T1. We just label them that way. And the way we think about the patient, Anna, she has two possible futures. If she were to receive medication A, her blood sugar 4 months hence will be something, and we'll denote this something by Y0. That's her blood sugar if she were to receive T equals 0. On the other hand, if she were to receive the alternate medication, T equals 1, her blood sugar would be some level Y1, possibly different, right? So ideally, we'd like to know these two possible futures and choose the best future for Anna. And of course, it doesn't have to be two, but in this talk, I'll focus on two. So these Y0 and Y1 are what are known as potential outcomes, developed by statistician Rubin, and even before that by Neyman, going back to the 20s, 100 years ago. And the quantity of interest, if we formalize this, is something called the CATE, the conditional average treatment effect. We'd like to know the expectation of Y1 minus Y0, the difference, conditional on X, where X is the description we have of Anna, everything we know about her, a feature vector. And ideally, we'd like to know CATE for X, for every patient X that comes in the door. Now, the challenge here, the problem is that we never directly observed this quantity that we want to estimate, because in our records, Anna either received medication A or B, and maybe she received A and a year later she switched over to B, but then that's not the same, right? A year has passed, she has already received medication A, she's not the same patient exactly. So this problem that we only ever see just one of the two potential outcomes for a given patient is what's known as the fundamental problem of causal inference. And just to make this harder, in most cases, if we work with, let's say, observational data with health records, we get to see Y1 or Y0 for Anna, but which of the two we get to see, the choice is not random. The choice is determined by how she was actually treated. And the clinicians treating her had their reasons possibly for giving her T0 or T1. So we not only do not observe CATE, the part we see only one part, but the part we get to see is not random and might be biased or confounded. So we want to estimate the CATE, and this is again in the Rubin-Neyman potential outcome notation. It's this expectation of the difference, which can be decomposed as the difference between these two expectations. And again, the way we interpret this is, what if we force the patients with feature X to receive treatment T equals 1? This is this, the E of Y1, versus what if we force them to receive treatment T equals 0? When I say force, that means irrespective of current treatment, because we're considering changing treatment. We're saying maybe such patients usually get this treatment or the other, but I want to know what will happen if we force them to get this one versus if we force them to get the other, irrespective of current treatment policies. And I want to know the answer to both these questions, and then that will help me make an informed decision which medication is better for this patient. And in our work, X will usually be some high-dimensional vector, essentially unique to each patient. For example, their entire patient record. And like I said, we never directly observe this. And we can't provably know the answer. So the difficulty for causal inference is that this what if, we can never know for sure. If Anna received T equals 1, never mind what sophisticated machine learning I'll throw at it, I don't really know what would have happened if I had time traveled back 3 years ago, change her medication and see what happened. I can hope to get a good estimate, but I can't know for sure. Now, just to kind of close the loop, how is this CATE quantity, which we'll try to estimate, how is it related to recommendation? So the high-level idea is we have an incoming patient and we'll estimate some quantity CATE hat using some method. And then we'll present the recommendation to the doctor. For example, we might say if higher is better, then if CATE of X is greater than 0, that means that T equals 1 will lead to higher outcomes. And again, if higher outcomes are better, then that's what we recommend. If CATE X for this patient is negative, we'll recommend T equals 0. So that's how we imagine the system eventually working, as recommending based on CATE. And of course, the threshold need not be at exactly 0. Any questions before I move on? This is just the general setup of Kate. Okay. So what I'll be talking here is at least a partial answer to what is needed to move from theory to practice. Okay, so from the theory of estimating Kate to actually being able to safely do this in the clinic. So first, how can we estimate Kate if I said like we can't know for sure what happened, what would have happened? So we can do this using more or less standard regression and machine learning tools if a strict set of causal identification assumptions hold. So the first assumption is no hidden confounders, and I'll elaborate about this soon. The second is common support between different treatments. And the third is no interference between units. And I'll focus on the first two soon. The important part is that most of these assumptions are not testable from data. So there's no statistical test that we can run and say, oh, these assumptions hold, now I can safely use machine learning. We're always in this kind of state of not fully being sure that we're doing the correct thing. The solution, so how can we hope to have the situation where these assumptions hold, is by study design. We need to understand what goes on in the clinics, how was our data collected. We need to dive deep in order to gain confidence that these assumptions hold, even though we can never prove that they hold, we can at least be more confident about them. And again, we'll go into that soon. Sorry. So one thing I won't talk much about, but I just want to say how, assuming everything holds, all these difficult assumptions, which we'll go into soon, hold, how do we actually estimate Kate? So here's a simple method. If these assumptions hold, the potential outcome just ends up being the expectation of the ordinary outcome, like the blood sugar of Anna, conditioned on her features and each of the treatments. So we can turn this, if the causal assumptions hold, we can reduce the problem of Kate to just an ordinary regression problem and just estimate these conditional expectations. And conditional expectations are like where regression machine learning shines. There are many, many methods to do that. And once we have some model which just says, oh, just does the obvious thing, I build a model that tries to predict Anna's blood sugar given her features and treatment 0, treatment 1. I use this model to estimate the K. The problem again is when can I use this model safely? But just to make it clear, if the causal assumptions hold, we can use any regression model we want. And there are many, it's a huge field, but the point is that even if the regression is done right, we might be wrong because of the causal assumptions going wrong. So just to list a few of these papers, so there's causal forest, and there's work using deep networks to estimate Kate. Some of it I was involved with. Gaussian processes, meta learning. So it's a huge and fascinating field, and I love it, but I won't go into it. I just want to say that I do work in it, and recently working on quantifying uncertainty in these estimates. And so if anyone is interested in that, I'm happy to talk about this after the talk. Okay, but just know that if the causal assumptions hold, we have a whole slew, like many methods we could use. Yeah.
So Uri, there's a question in the Q&A I think might be good to address now. It's X is high dimensional. Can we know how many of the dimensions and what are those? Different time, will those dimension content change, and how to deal with this time-related change?
So yeah, that's a good question. So usually I assume that we know very well what each feature means. It might be a lab test over time, might be doctor's notes, extracted from doctor's notes. We focus here, just for simplicity, on tasks which are at a point in time. So the feature vector, I need to build it carefully to summarize the entire history of the patient. And that's like, there are many ways to do that. And it's there are good questions to ask about that. But I build somehow I build a feature vector that summarizes the history. And then at this point in time, say this describes my patient, so I don't have to worry about change. If the patient comes in next year, I recompute their feature vector based on what happened in the intervening year, maybe taking into account the treatments this patient has received and how they responded to them. I need to somehow encode that into the new feature vector and re-estimate their Kate and my treatment recommendation. I hope that answers the question. Okay. So my focus would be on these causal identification assumptions. So the first and maybe most famous one is hidden confounding. So the assumption that we need to make in order to run all these fabulous Kate methods is that there are no unmeasured factors that affect both the treatment and the outcome. Common support means that the population that received one treatment versus the other is similar. And we also need, this is not strictly an assumption, but we need this to in order to be useful, we also need to be able to accurately approximate the outcome, right? If I can't just predict what will happen, if the outcome is after, okay, sorry. So there's a third thing that we need to happen, which is not strictly an identification assumption, but just we need our regressions to work well. If we try to predict a patient's, let's say, blood sugar in the future, and we just have no way of predicting it, if it's highly variable, if our regressions have very low R squared, then kind of we don't have much hope of making anything useful or recommending treatment. So that's not a strict assumption, but it's something that we need. So how might these assumptions fail? So here's a typical scenario where we might have hidden confounding. Let's say treatment. So a confounder is something that affects both the treatment decision that we see in the data in the clinic and the hospital and the outcome. So what if a treatment was assigned based on some unrecorded patient preferences? Some patients might prefer pill versus injection, or have different side effect preferences. And this patient preference might be correlated with their outcome, with their health status, and so on. So maybe there was this conversation between the clinician and the patient, which is not recorded in the data, and that might confound our estimates. And if that happens, we're in trouble. What if treatment is assigned based on some soft criteria? For example, how much support does a patient have at home? Like if they're maybe elderly and you're about to release them home, and that might affect the treatment decision. Again, might not be recorded in the data, and then we have problems. If it is recorded in the data, then we're fine. But these kind of things are often not recorded and might be important because how much support the patient has at home might affect their outcomes, irrespective of the treatment they receive. So these are scenarios, these are failure scenarios of the no hidden confounding assumption. Okay. And maybe there's just important clinical data which is available to the, maybe the clinician looks at some image, like a CT image, and we just don't have that CT image as analysts. And then again, we're in trouble. The way the overlap or common support assumption might be violated is if treatment has clear guidelines. If you say patients of this type always need to receive T = 0. If Anna has a guideline, there's a guideline that says, oh, Anna, with her clinical record, she has to receive T = 1. I cannot hope to estimate what would have happened to her under T = 0, because I never see patients who are like Anna receive the alternate treatment because there's clear guidelines. So assuming the guidelines are adhered to, then I have no way of inferring these counterfactors. And that is often the case, right? There are many guidelines in medicine. And also, this need not be an official guideline. Maybe there's some unofficial kind of, this is how we do it here, which also happens in the specific hospital or ward. And again, patients like Anna are always treated one way and not the other, and then we cannot infer the counterfactors. Okay, so each of these will make valid causal inference impossible. So what we'll do now is outline tasks where we hope we can address all three of these concerns, like the confounding, the support, and accurate effect estimates, and still be useful. So this is designing the study for causal identification. And so how do we design the observational study to be able to identify causal effects? And the task we kind of narrow down to is what we call clinical point-in-time decision support. And I'll now give kind of the conditions that we think will make all these assumptions more plausible. One is that we're dealing with a treatment decision or dilemma, which is made by a physician at a well-defined point in time. There's one point and they have to make a decision now. It's not something that goes on over like a year. The set of possible actions is small. This is mostly for statistical reasons. So we might have similar patients who receive different treatments. If there are many, many different actions, it becomes statistically very different. We need a problem, a decision where there are no clear clinical guidelines. If there are clear clinical guidelines, like I said, we will violate the overlap assumption. And also if there are clear guidelines, maybe our help isn't needed. Like, this is what you do. And we further need there to be high variability between physicians. That it's not strictly necessary, but we found it very helpful. If physicians kind of one of them does this, one the other, that is our source of randomness. That is what allows us to maybe replicate kind of the randomness we would get, for example, in the clinical trial. And finally, we need well-defined and widely agreed outcomes to optimize. Like, physicians have to agree, this is what we want to improve. It doesn't have to do one thing, but they have to agree. Okay, so why do we think this setup, like in this specific setup, we can actually estimate causal effects? Because the physicians make a single decision at a single point in time, it's very clear what was the patient's state at that point in time. We know their record, assuming we have the data. Physicians have some insight into their process. Remember that confounders are some things that affect both the treatment decision and the outcome. And we can ask physicians, what do you take into account? Do you ask the patient this question or not? Do you look at this variable or not? So that is very helpful, and this discussion is crucial because this discussion tells us what should we measure. And usually humans can't consciously consider more than a couple of dozen factors when making decisions, which means we might have a chance of having all this data at our hands. Of course, it depends on our data. We don't always have it, but we at least know what we should have. And if a physician tells me, oh, this is an important field, we always ask like whether a patient exercises or not. I can look at my data and see whether it's recorded or not. If it's not, I have a problem. But if it is, I'm satisfied. And of course, this is not perfect because we also have non-conscious factors going on that we might not be able to control. So even this is not perfect. Moreover, we don't need to estimate the true effect for each patient correctly. We really just need to give a useful recommendation. So our task is a bit more humble. We don't need to get the true effect for each and every patient. We just need to say, oh, in cases where physicians aren't sure, we recommend something, and that recommendation has to be useful. And the places where physicians are uncertain are both the places where we have the best data, because they could, like, treatment could really go either way. And it's where our help is most needed because they are uncertain. So that's a good situation. And finally, we also have no recommendation option. Like, we don't have to recommend. If we're not, we have an option of saying we're not sure here. I'm sorry. So again, just to go over this, why we think the scenario is good for causal identification. Hidden confounding is mitigated by the fact that we're looking at a decision made at a single point in time, consciously, by someone who is trained to make this exact decision. The common support assumption is we're comfortable with it because we focus on exactly the cases where there's explicit decision uncertainty by the physicians, and the need to estimate effect accurately is mitigated by the fact that we just need basically this sign. We need to know whether this is better or worse. We don't need to get the exact number, and by the fact that we do not feel beholden to give a recommendation for each and every patient. Okay, so let's skip this. Okay. And we will see two examples where we try to apply our framework, which I'll soon explain. One is for chronic disease, second-line medications for diabetes type 2. And one is an acute disease, treating acute kidney injury and hospitalized heart failure patients. So we outlined this scenario, which we think is general enough to be useful in many situations. And we have two examples where we think causal identification will hold. And what we're working on now is developing this entire pipeline, which I will not go into the slide. This is just to eye you by the many beautiful rectangles of how to exactly do this. So step-by-step thing of how you could run by and see, does the scenario, is the scenario reasonable? And then all kinds of sub-modules you need to develop in order to gain confidence in your Kate estimate and your treatment recommendation. And, oh, I see a question. How would you handle a variable X, say, such that the treatment affects X and then X affects the outcome? Variables that are affected by the treatment should be thrown away. They are post-treatment, and including them in a model will induce bias. So we need to be very careful and not to use these. Note that if we're thinking about deploying a system, we will not have in our hands anything affected by X, right? Because X has not been, like the treatments are anything affected by the treatment because the treatment has not been decided. If the patient has received the treatment in the past, I might include this as a feature, as a covariate, and that's fine. So we have this entire process, and the focus is on the process, not like on the how do you exactly estimate Kate, but on the higher level process. And I'll give some examples of this. So here's our first study. It's about chronic disease, and we're investigating the effects of sulfo versus DPP-4, which are two medications for type 2 diabetics. And these are second line. So these are patients who have not responded to the first line therapy, which is metformin. And the goal is to reduce blood sugar measured in HbA1c. We had, and sorry, this is with Khezeli Health Services, the biggest health service provider in Israel. And we had more than 50,000 patients in this study. And we measured more than 200 covariates, which we thought were potential confounders, things that might affect the treatment decision and or the outcome, and like demographics, their lapses, diagnosis, medications, many administrative covariates, and so on. And we discussed with the Khezeli physicians to understand how is this decision made. So to make sure we are in this clinical point in time decision making. And yes, they tell us they see the patient, they might know the patient before, but often they don't know them very well. And they just, oh, you had metformin, your A1C is still high. You should take DPP-4 or sulfo, or there are other medications, but we focused on these two. And we asked them, what do you take into account? What happens in this discussion? What do you look at in the patient's record to make sure that we don't have any hidden confound? And once we were satisfied that this problem is plausible and we're in a good state, we go into this 10-step flow. So I'll go over these 10 steps, and these are kind of the shortened version of the full pipeline, which was that big multi-rectangle slide before. So this flow is as follows. So we start with a target system, and we need to define it with the clinical collaborators. So what is the decision point exactly, guys? Like, when do you need the recommendation? What are exactly the treatments? What are the outcomes? For who is this relevant for? Okay, so this sounds maybe banal, but this is really important. And it took us a while to narrow it down to understand exactly what are we aiming for. And it really helps clarify the discussion. Once we have this target system, we need to ask about confounders. So what factors drive treatment and outcome? And maybe they're not in the data. If they're not in the data, how do I get them? And this might be kind of a loop. We might have to say, oh, this problem is we need more data. So let's gather more data. We need to change our definition of the population. Maybe for some population, we don't have this data, for another we do. So this is a back and forth until we're satisfied that we have a system where causal identification plausibly holds. We have no hidden confounders. We have common support. I'll skip this. And we step 3, I'm happy to talk about later why it's important. Step 4, so once we're satisfied, we build what's called a propensity score model. So this is a model of the treatment assignment. We try to predict what the physicians will do, okay? Not the outcome, just the treatment. And this model is important in many Kate estimation methods. It's helpful mathematically, but it's also helpful to estimate overlap. So this is the calibration of this model. Okay, so just that we run the model, on the Shalit data, and we see that it's very well calibrated. And when we examine the model using something called CHAP values to see if it makes sense, we see, for example, that one of the things that predicts a patient receiving DPP-4 instead of sulfo is if the patient was treated by a specialist as opposed to a general practitioner. So this makes sense. DPP-4 is the newer medication, and we see that specialists, endocrinologists, are more likely to prescribe the newer medication, and general practitioners or people from the periphery of Israel tend to prescribe the older medication. Okay, so the reason we do this is to see that it makes sense. We check ourselves every time to see that our models are plausible, that we're not missing something. And then we draw this histogram of propensity scores between the treated and control. And we see these two edges of the distribution. What are these patients on the right-hand side? These are patients who very likely would get the treated T equals 1 and almost never receive T equals 0. These are patients for which we have violation of overlap. So for these type of patients, they are always treated with sulfo or always treated with DPP-4. Mostly it's the DPP-4. Some patients will never receive sulfo. So for these patients, we throw them out. We say we have no recommendation because we can never infer the counterfactual for these types of patients. And we try to identify who they are and so on, but I won't go into that. So this allows us to feel more comfortable about the overlap, because for some patients, say there's no overlap. We can't infer counterfactuals. That's fine. We don't have to give a recommendation for everyone. We're satisfied with that. And once we did that, so we started with 50,000, we ended up with, we had about 40,000 patients for which we tried to make a recommendation. For the rest, no recommendation. So now we have a new target population, right? The people within the common support region. Once we have this new target population, we start to build outcome models. So first we model how the physicians treat the patient, just to know for which patients can we plausibly infer counterfactuals. Once we have this subpopulation, we start to build outcome models, models that say, what will this patient's A1C be given their entire feature vector and their treatment assignment and so on. And we build multiple models, again, just for robustness, to see that they agree, that we're making sense, because it's easy to delude ourselves with one model which is overfitted or has its own peculiar biases. So we did something simple here. We just fit two different models. It's something called sometimes a t-learner. So there's a model that predicts what will happen to a patient under DPP-4, and a model that predicts what will happen to a patient under sulfo. That's not the only way to do that, but that's what we did. Used XGBoost and ridge regression. We also used a different model which directly tries to estimate Kate, something called causal forest, which is very nice. It's a kind of version of random forest for Kate. And we looked at the causal estimates for all three. For the t-learners, we could examine RMSE. So for the XGBoost and ridge regression, we could just say, oh, does it fit the data well? If it doesn't fit the data well, we're in trouble. And we see it fits it reasonably well. I would have liked this to be tighter, but this is on a test set, the two models, the sulfo and DPP-4 model, the predicted A1C versus the observed A1C. And it at least makes sense. It doesn't fail. And once again, we remove some more patients. So for some patients, our models don't have a very high confidence of the sign of their Kate. Maybe the prediction interval was wide. They say, oh, this patient might be anywhere between +1 and -3. And we're saying, okay, for these patients, we don't give a recommendation. We're fine with that. We're comfortable not giving recommendations for everyone. The following step is to perform sensitivity analysis, which is basically to say, okay, what if there is hidden confounding? I tried to design my study so there isn't, but what if there is? How badly will things turn out? And there are not many ways to do that for Kate models. I will not go into this, but I will promote our very recent paper, which gives a very nice method to this from ICML 2021. Then we start to look at the population, say, okay, we have this recommendation. We want to be really sure it's okay before we deploy it, before we start changing treatment. So let's see, who do we think should get DPP-4 and who do we think should get sulfo? Let's investigate also, where does our model disagree with what actually happened? Like, where do we think the doctors went wrong? Does it make sense? Maybe we're wrong and the doctors are right, right? So let's investigate these populations. So we use all kinds of methods to do that, but basically it's just looking at these patients and trying to kind of characterize them. So here's an example. These are the result using the XGBoost method of the Kate in units of delta A1C. So we say that sulfo versus DPP-4, how much different will the A1C be for patients? So we see that the distribution is mostly negative. So for most patients, our model believes that they should get DPP-4. The median is minus 0.16, which is not a lot. So we don't think there's a big difference between the two. For the 25,000 patients, so we had disagreeing with actual practice for 8,500 patients. We think they wrongly received sulfo, and only 1,000 patients wrongly received DPP-4. And the marks here, the quotation marks, are because it's just a model, right? We can't know for sure that we're right. And what we saw is that most wrong sulfo were treated again by general practitioners as opposed to specialists, which makes us feel a bit more comfortable saying that really our recommendation could have helped. Maybe these doctors are not so up to date. They would have received the recommendation and would have been better off. Is personalization worth it? So we ran our model. And for each patient, we had, oh, they should receive DPP-4, they should receive sulfo, we think. But is there anything personal about this? So in diabetes here, in the diabetes case, so far, the answer seems to be no. We detect no significant difference between the following two things. Just move everyone to DPP-4, the newer medications, or personalized treatment and say, oh, this should get DPP-4, this should get sulfo, because most patients should probably get DPP-4. So maybe there's no point, like there's no need for some sophisticated system. So this is of course disappointing for us, but it's maybe a happy conclusion, because it says, oh, the problem is easy, just give everyone the newer medication. The problem is made more complicated by the fact that there are even newer medications than DPP-4 introduced recently. And for them, we still don't have enough data, enough patients treated, enough follow-up time to be sure what happens, but we are following up on that. So here we use our pipeline and basically recovered results from a big clinical trial that was ongoing at the same time, which says basically DPP-4 is better than sulfo. But even the clinical trial doesn't tell you, just tells you the average. And we say basically there's nothing going on here more than the average. It's all about the average in this case, which again, personally is disappointing, but maybe it's clinically easier. We use the Python version, but I don't know where it ran. It ran on the Shalit servers, so I'm not sure what they did there. Like it was, we didn't have direct access to that, to the servers. Okay, so the second study is with Rambam, is with the University Hospital of Mayo University. And this is investigating the causal effects of diuretics on kidney function in hospitalized acute heart failure patients who have kidney injury. So basically, these are pretty sick patients. These heart failure patients, and their mortality is 30-something% within 1 year of hospitalization. And I'm vastly simplifying this, but the treatment these patients receive for their heart failure problem often causes kidney problems. So there's this difficult balancing act. And the physicians tell us they have poor guidance how to balance this. And we're kind of focusing on one aspect of it, which is how to prescribe diuretics. So they're not sure whether to increase or decrease the level of diuretics these patients are receiving, because it might help kidney function, but hurt the heart function and vice versa. So we have 2,000 patients, again, many covariates from the hospital. And this is acute care. So these are hospitalized patients, they're in the hospital. And empirically, about half of them received increased diuretics and half decreased. So these are our two treatment arms. Again, we're simplifying the problem. There are more than two, but we're just saying you can either increase or decrease the diuretics. And like I said, decreasing might improve kidney function, but hurt cardiac function. And it's a difficult balancing act. So for now, we only examine the effect on kidney function. Our next step is to examine the effect on heart function, so we can kind of give a fuller picture to the physician. Say, if you treat this way, this is the kidney function, this is the heart function. You choose, like you choose how to combine the two. But kidney function is just easier to measure in our data, so we focus on that. So we ran the entire pipeline. I will not go into this. I will just focus on the last part, which is what we call policy values. And I'll explain what this is. We saw that this Kate estimator, we can derive a policy recommendation for treatment, right? We say, oh, you should treat this patient this way, this patient that way. And mathematically, it's just the indicator function for whether the Kate hat is greater than 0. Or we can say, we can treat only if Kate hat is greater than some threshold, which is not 0. It's like, I need at least this much benefit to recommend this treatment versus the other treatment. For any policy, so we call this a policy. A policy is how to treat each and every patient individually. Any policy, we can estimate its policy value, which is the expected outcome if patients were treated by policy pi. We can say, oh, if they were treated according to our recommendations, if every recommendation was followed, what do we estimate would have happened on average to the entire population? Okay, so there's the current policy value, which is just what happens currently under the way doctors currently treat, and we hope to do better than that. We hope our policy value under our policy, which, like we saw even earlier, differs from the physicians for some patients, we hope to improve. So we hope the aggregate outcome will be better for the population. And we can estimate this using inverse propensity weights. If you don't know what that is, never mind. But if you do, it's similar to other causal inference problems. And specifically, we use something called a doubly robust policy value estimator from Dudek et al. So the question here is to increase or decrease diuretics. Again, we ran our entire pipeline. The policy value will be presented in % improvement in kidney function measured by creatinine return to baseline. So basically 100% is excellent. It means the patients are really back to their baseline. 0% meant we did nothing. So we ran our entire pipeline. We took our test set of 530 patients. We had recommendations for 461. So for 69 patients, we say we don't know for all the reasons we saw above. We're not sure about the effect and so on. We used XGBoost and T-learner, and this is what we get. So here I present the policy value. So this is if we just increase the diuretic interval. So the policy value is about 20-something%. This is what happens in practice. So this is what the doctors currently do, and this is the policy value as it currently is. This is a random policy. If we just randomly treat people, we see it's about as good as what the physicians actually do. And when I showed this result to our collaborators, the clinicians, I thought we had a problem or a bug, and they said, no, this makes sense to us. We really are not sure how to treat these patients. We might be doing just as good as random. Here's what happens if we decrease everyone. So this is slightly better. And this is our Kate policy. So this is a personalized policy, which is slightly better than decrease everyone, but not statistically significantly better. So what's going on here? We can show that our recommendation, the Kate hat policy, is better than current practice. So p-value 0.05, that it is better. Our recommendations have approximately the same policy value as decreased diuretics for all patients. But you can't really decrease diuretics for all patients. We only recommend decreasing for 50% of the patients, and that gives much more flexibility with respect to the other outcomes. So there's a reason not everyone is decreasing diuretics, because it has other ramifications. So our policy is better than the doctors, and it offers more flexibility with respect to the other outcomes. But we want to know the effect on the other outcomes, and that is work which is currently in progress. Okay, so I'll skip this and just get to my next to last slide. So should we believe this? We saw that, for example, one of our policy recommendations, it seems to do better than what the doctors do. But we don't really know what would have happened in the cases that didn't follow recommendation, right? We don't really know. We estimate using all our models, and we had all this design of a clinical point in time to give us confidence that there's no hidden confounding, but we can't know for sure what would have happened to a patient if they were treated differently. The only way to truly know if our recommendations are useful is to run an experiment testing the system with real physicians and real patients. So having a system which gives a recommendation, the physicians are free to follow it or not, and see if just the presence of this recommendation improves the outcome. So that's the clinical trial we're ultimately aiming for. Okay. Okay, so I'll just thank the people who did most of the work. So Ron Gutman and Shimon Shaiba are students from my lab at the Technion, Professor Doron Aronson and Dr. Oren Kaspi from Rambam Medical Center and the Technion, and other people at the Elite Research Institute who collaborated with me on this project. So thanks to everyone. And thank you very much to you for your time and attention. And I'm very happy to take questions now.
Thank you very much, Uri, for such an interesting talk, from the overview of unobservable confounding variables to the clinical guidelines for clinical trials. The audience, please post your questions in the Q&A tab at the bottom of the Zoom screen. I have a question actually about the confounding variables and the guidelines. So as we include more and more features, increase the dimensionality of the problem, the challenge with that is you may lose the statistical power that you have and increase the uncertainty into your estimate. So that's, on the one hand, adding more features reduces the possibility of having confounders. On the other hand, that's the statistical problem. Any suggestions for that sort of situation?
So it's definitely something we were concerned with. I would say the problem is it doesn't hurt. It hurts the common support, right? The patients seem more different the more you know about them, right? Eventually, every patient is unique, right? So, and that is a problem. The textbook answer is, and that's one of the things I skipped kind of in the 10-step thing, is you should remove variables that are only predictive of outcome, only affect the treatment, sorry, and not the outcome. Things that, for example, if you have, I know, the patient, the physician ID might be such a thing. So these things will provably just increase variance and not buy you anything in terms of confounding. The problem is, and that is an open problem, is what we call almost instruments, which are variables that affect the treatment strongly, affect the outcome weakly. If you remove them, you have hidden confounding. If you include them, you have high variance. And there's no really good way to balance these two that I know of, except for simulations, trial and error, and so on. Our approach is anything that the physicians clearly say is important, we have to include. But then you have all the long tail of all the stuff that is maybe important, maybe not. And it's hard. So we don't have any clear-cut rule on how to do this. So you're raising a good point, and I don't have any satisfying answer except to kind of, at some point, we need to make a decision, and we base it on the propensity scores and our precision in the outcomes, but it's heuristic. The bottom line is it's heuristic once we address all the important confounders.
Thank you. There are some questions from the audience. One is on the diabetic experiment. So is change in A1C the only outcome measured? What about other possible side effects?
So we looked at a few other outcomes. Again, for the purpose of this, we want to focus on one just to kind of run the entire pipeline. We looked at others. I don't think we had any final answers because some of the side effects were not as well measured as consistently. And some, we just had problems accessing the data for example, cardiac outcomes. Just technical problems, the data is there, but we couldn't access it for various annoying reasons. Ultimately, because we didn't find anything very interesting there, we kind of never pushed forward with this to get all the data. Moreover, we have like these newer medications, which are what's really interesting now. So in practice, we kind of just dropped this. But in principle, or for systems that we actually mean to deploy, we will definitely look at side effects as if they're important. If they're important for the clinical decision, then we are obligated to look at them. And that's something we need to hear from the physicians, right? What do they actually care about when they're optimizing treatment? And I think that actually goes to the second question also. So Kate is better than doctor, will doctor lose job? I don't think doctor will lose job. No, I don't think at all, because usually there's more than one outcome you're optimizing. Usually there's several, and weighing them together is not just a clinical decision, it's kind of a human decision, right? You need to talk with the patient, understand their preferences, what's important to them. It's a higher order question. And our goal for our systems is to help this discussion. I don't think, maybe for specific cases, we'll be like, okay, this is better than doctor. This will just give the doctor more time to do other stuff, right? So it might save kind of a sliver of the doctor's work in this case, but it won't make the doctor lose their job. And we're not even at the point that we're sure we're better than the doctor, right? We're not even there. And we'll have to see about that.
So, Uri, I have a question that kind of popped in my head early on in your presentation when you listed those strict set of causal assumptions, the no hidden confounders, the support. So in some of our internal applications of doing causal estimation at Mayo, one of the things, after we discuss these assumptions, one of the common comments that we get from clinicians is, yes, these assumptions are not testable with observational data. Can we leverage experimental data in some way, even though it's lower in number in terms of subject size?
Yes. So actually, that was one of the bullet points I skipped. Also, definitely, there are ways to do that. I have a paper about that from a few years ago, and just now, actually, there was a new paper out, like giving new ways to combine these two. It's the basic idea is that clinical trial data is small but unconfounded, right? So they're kind of complementary, right? You have lower statistical power but better causal power in a way. And it's a very interesting question how to combine the two. I think in practice, maybe in Mayo you have that. Often it's really hard to access the detailed clinical data. You don't just clinical trial data. You don't just need the bottom line, right? You need this subject. These were their covariates. This was the outcome. And even if you have access to that data, and I'm actually currently working with a company who runs these trials, it doesn't match the data from the electronic medical record, right? So I'm not saying it's useful, but it's still like there's some more work to be done.
Right. There's some hurdles for sure. Yeah.
Exactly. But it's I think the future will have to be this way. Right? We'll have to use all the data we have to be as best as we can, be as good as we can.
So we have two more questions we can try to answer in the last 5 minutes. First one, have you tried 2SLS to alleviate instruments?
No, 2SLS is two-stage least squares. It's kind of the standard method to use instrumental variables actually to estimate causal effects. We have not. If we know a feature is an instrument, if we're reasonably sure, we can just throw it away. That's actually the correct thing to do because it just gives you variance and nothing else. The problem was with these almost instruments where it's not clear, you have this bias variance trade-off. If you include them, you're weakening your common supports, or you have a lot of variance. But if you throw them away, you have confounding. So it's not clear how to balance these two. And there are simulation studies about that, but I am not aware of any good kind of, this is how to do it in real data, real high dimensional data. And this is another kind of open research question.
Then the last question is, how does your pipeline handle missing data? Since it's personalized recommendations, can you include variables which are only measured in some patients?
Yes, so we obviously had missing data. All health data has missing data. We used imputation methods and so on. Our pipeline handles it. It will be as good as your missing data imputation method is, right? So if you have kind of severe missing data problems, that will impact everything. And it might actually induce hidden confounding and so on. But it's kind of just part of the pipeline. There are, if you want to dive into this, there are some interesting interactions. You might, if the missingness mechanism can be confounded in itself. So Julie Josse from EPFL, she has, not EPFL, from from France, but I forgot the name of her university. She has some interesting work on the interaction of missing data and these causal assumptions, and how to make them work. Sorry, she's from École Polytechnique now, I remember. So that's interesting. But again, just in our case, we kind of didn't dive too deeply into this. We just said, okay, just use the best imputation we have and run with it.
Great. So we've reached the top of the hour, and I really want to thank Dr. Shalit for joining us today and providing a terrific talk and primer on how to use causal estimation and causal inference methods for making treatment recommendations from patient records. I know we at Mayo Clinic, we're very interested in applying these types of methodologies and enhancing the practice. So if anyone in attendance has any lingering questions, please feel free to contact Dr. Shalit or any of the panelists for a follow-up. And please stay tuned for upcoming talks in this AI speaker series. Take care, everyone.
Thank you very much. Thank you for having me. Have a great day.